Malnutrition, condition of undernutrition or overnutrition. Terminology in undernutrition. Wasting, stunting, underweight. Wasting parameter, low weight for height, weight upon height. Implication, acute severe weight loss. Recent. Stunting is low height for age, chronic undernutrition. Underweight is low weight for age, can refer to wasting and or stunting. WHO classification of malnutrition based on WHO charts: wasting, moderate malnutrition, severe malnutrition. Wasting moderate malnutrition is when it is between -2 to -3 st. Severe malnutrition is less than -3 st. Stunting is moderate nutrition is -2 to -3 st. Severe malnutrition is less than -3 st. Symmetrical edema is absent in moderate malnutrition and is present in severe malnutrition. Clinical syndromes and malnutrition: protein energy malnutrition, marasmus and kwashiorkor. Predominant deficiency: in marasmus, predominant deficiency is calorie. In kwashiorkor, it is protein. Onset is less than 1 year old in marasmus, 1 to 4 year old in kwashiorkor. Edema is absent in marasmus, is present, and also there is anasarca, generalized edema, in kwashiorkor. Muscle wasting is present in marasmus and is present but masked by edema in kwashiorkor. Appetite is good in marasmus and it's poor
General
in
appearance. So for marasmus, the babies, you'll find them, they are alert. And remember that marasmus is only calorie deficit, right? So the skin, and they have skin and bone appearance. They have loose skin folds in axilla and buttocks, like a baggy pant appearance. Hair are thin and brittle. They have simian faces due to buccal fat loss and wrinkles, old man face, and they have loss of muscle mass. That is your marasmus. Wasting of muscle and fat both is occurring. While in your kwashiorkor, they are dull, lethargic, irritable. Skin is like flaky paint appearance, hyperpigmented patches, flax sign, alternating gray and black patches in the hair. Serum albumin is low, decrease oncotic pressure, and it causes anasarca, generalized edema, crazy pigment appearance due to cracks on skin, lusterless hair. They also have hyperpigmented brown patches and mental changes. They could be apathetic or irritable. Coming to severe acute malnutrition, that is your SAM. Criteria: you have visible severe wasting. There should be visible severe wasting, and weight for height should be less than 3.5 standard deviation. Then bipedal edema, and mean arm circumference should be less than 11.5 centimeters. Decrease albumin, decrease oncotic pressure, fluid goes outside. Then also renal failure, cardiac failure can also be causes of pedal edema. So you have to check that if it is due to malnutrition or renal failure or cardiac failure. Presence of any one of the above is severe acute malnutrition. Types of SAM: it could be uncomplicated or complicated. Appetite is good in uncomplicated. There is no generalized edema. There is no medical complication. What you have to do? Supervised home management. Coming to complicated severe acute malnutrition, the poor appetite is poor, edema is present, Complication is present. Interventions, hospital management. Hospital management of SAM. Nutritional goal. It is 175 kilocalories per kg per day. That is 175 kilocalories per kg per day, and protein is 4 to 6 gram per kg per day. So for hospital management of SAM, 175 kilocalories per kg per day and 4 to 6 kilogram per kg per day of protein. Diets, you need to give homemade foods, you need to give ready to use therapeutic foods. Ingredients are milk, solids, sugars, vegetable oil, peanut butter and paste. Advantages, it has good palatability, semi-solid consistency and long shelf life. Nutrient value, nutrient value of ready to use therapeutic food is 543 kilocalorie and 15 gram protein per 100 grams. Additional interventions. Antibiotic, you can give oral antibiotic for 5 days. Albendazole deworming dosage less than 2 year or more than 2 year. So if it is less than 2 year, then it is 200 milligram. If it is more than 2 year, then it is 400 milligram. That is your albendazole for deworming. Vitamin A dosage, so that is divided into less than 6 months, 6 to 12 months and more than 12 months. Less than 6 months, you have your 50,000 international unit. Between 6 to 12 months, 1 lakh international unit of vitamin A. More than 12 months, it is 2 lakh international unit of vitamin A. Hospital management of SAM. Management, stabilization phase and rehabilitation phase. Stabilization phase, management of severe acute malnutrition. Stabilization phase, management of complications, mnemonic shielded, and rehabilitation phase. Phase 1, stabilization. Complications that you can see is hypoglycemia, hypothermia and infections, and electrolyte imbalance and dehydration and micronutrient deficiency. This and the 3 complications like hypoglycemia, hypothermia and infections, this 3 complication occurs together as a triad. So how do you stabilize hypoglycemia? Hypoglycemia is when the blood glucose is less than 54 milligram per deciliter. Treatment, if it's an asymptomatic hypoglycemia, you give oral glucose 50 ml. If it is symptomatic hypoglycemia, for example, seizures are happening, then you give IV 10% dextrose up to 5 milligram per 5 milliliter per kg stat and through glucose infusion. IV 10% dextrose 5 ml per kg stat. Definition, axillary temperature should be less than 35 degrees Celsius and rectal temperature should be less than 35.5 degrees Celsius, then it is called hypothermia. Treatment, warming child using protective clothing. That is the treatment. Also, you can give kangaroo mother care in infants. Then infection. It is because of decreased immunity. Usual signs may be absent. Empirical treatment is started in all children of severe acute malnutrition. Most common antibiotic is ampicillin and amikacin. That is your penicillin plus aminoglycoside. If no improvement is present in 48 hours, 3rd generation cephalosporin, for example, ceftriaxone. Most common bacteria is gram negative. Electrolyte imbalances, sodium levels are to increase total body overall, excess sodium avoided. Serum sodium low normal due to intracellular sodium and dilution effect of edema. Hypokalemia and hypomagnesemia treatment supplementation. What are the electrolyte imbalances that you see in severe acute malnutrition? Sodium levels. There is increased overall total body because excess sodium should be avoided. Sodium could be low or normal. It is due to intracellular sodium and dilution effect of edema. There can be hypokalemia and hypomagnesemia, and treatment is done by supplementation. Dehydration. All children in SAM have some dehydration. Clinical symptoms of dehydration are thirst, urine output, and dryness of oral mucosa. Treatment start irrespective of symptoms. If there are no shock symptoms, then you give oral fluids, rehydration, solution of malnutrition, Resomal. That is the treatment if there are no shock symptoms. If there are shock symptoms present, then you give ringel lactate with 5% dextrose. Contains potassium ions. First 2 hours, 15 milligram per kg per hour. If there is resolution, then oral fluids you can shift. Skin pinch test is unreliable as it depends on subcutaneous fat. Micronutrient deficiency. Multivitamin supplementation is recommended for all severe acute malnutrition. Dose is twice the recommended value. Iron absorption in first week is reduced. Unabsorbed iron, free radical damage, promote bacterial proliferation. Rapid rewarming should be avoided as it causes disequilibrium syndrome, causes drowsiness, seizures, coma. Hypoglycemia, hypothermia, and infection usually occurred as a triad. Treatment initiated for all three of one, if all three, if one is present. So if anything like hypoglycemia, hypothermia, and infection is present, anyone is present, then you start treatment for all three. Skin pinch test is an unreliable indicator of dehydration as there is low subcutaneous fat. Rizomal versus WHO ORS solution. So WHO and Rizomal, what is the difference? Osmolarity almost same, WHO has less. Sodium more in WHO. Glucose less in WHO ORS. Potassium less in ORS. Chloride less in ORS. Everything is less in ORS except sodium. Sodium is high. Otherwise everything is less. Osmolarity of ORS is 245 and of Rizomal is 300. Phase 2 rehabilitation. Mnemonic best rehabilitation. Beginning of feeds up to 1 week. Cautious feeding. F75 diet used. 75 kilocalories plus 0.9 gram. Protein per 100 grams. Goal 80 kilocalories per kg per day plus 0.8 to 1 gram per kg per day protein. Energy dense feeds after 1 week for catch up growth. F100 used 100 kilocalorie for 20 gram protein per 100 gram. F100. So energy dense feeds is after 1 week for catch up growth. F100 used 100 kilocalorie plus 2.9 gram protein per 100 gram. That is your F100. While in F75 there was 75 kilocalorie and 0.9 gram protein per 100 gram of diet. Goal 175 kilocalories per kg per day plus 4 to 6 gram per kg per day protein. Sensory stimulation. Transfer to home care. Prepare for follow-up. Stabilization and rehabilitation. Stabilization day 1 to 2. Hypoglycemia, hypothermia, dehydration. Stabilized in 1 to 2 days. Electrolytes keeps happening, the management keeps happening up till 2 to 6 weeks. Infections keep happening up till 7 days. Micronutrients, no, it starts from the beginning and up till weeks, but in the beginning you don't have to give iron, then you have to give iron at the end. Cautious feeding up till 1 week. Catch up growth is after 2 weeks. Sensory stimulation is up till 6 weeks. Prepare for follow up is up till between 2 to 6 weeks. Treatment completion. No edema for at least 2 weeks. Then the treatment is completed. No edema for at least 2 weeks. And weight for height minus 2 st. Mean arm circumference reach 12.5 centimeters. So when do you say your treatment is complete? First of all, no edema for 2 weeks. Then your weight for height is within minus 2 st. And your mean arm circumference reaches 12.5. Deworming is done to be prior to discharge. Albendazole 400 mg single dose. In the next video, we'll continue with obesity.